Hi guys, the next topic on the agenda is to talk about sarcoidosis, which is characterized by non-caseating granulomas. I have described non-caseating granulomas even in literature of ulcerative colitis and Crohn's disease, whereas in pathology you have talked about caseating granulomas, which is going to be seen with histoplasmosis or cryptococcosis or tuberculosis. Now, before I describe a case-based scenario of this particular disease before you, I need to explain what body organs are usually involved in this condition or are relatively less commonly involved, because that will have some ramifications from the prognosis perspective. The most common organ involved in this condition happens to be the lung, but because this is too easy for you to crack, there's a distinct possibility that in the MCQ he may not have lung in the options, and then your answer would be given as skin. That is where you read about lupus pernio or you read about erythema nodosum as a dermatological manifestation of the disease. In contrast, if he says which is the least common organ involved in this condition, then your answer would be heart. Yes, the non-caseating granulomas can involve the heart as well, and unfortunately can cause the conduction system of the heart to misfire. If he specifies what is the leading cause of death in a case of sarcoidosis, because it's going to be lung involvement, therefore respiratory failure can occur. You see, respiratory failure itself is of two varieties, type 1 and type 2, that I've discussed in the pulmonology section. But I just want to highlight that if you encounter a question that begins by saying what is the number one cause of sudden death in a case of sarcoidosis, then the entire domain of the MCQ will change. You see, overall I was saying lung involvement, respiratory failure, but when he says sudden death, then because of the misfiring of the electronic circuit in the heart, then arrhythmias definitely can occur in this person, and tachyarrhythmias can cause crashing of the blood pressure and this person can die. I also want to bring to your notice that if this person is dying, especially when he's on medical treatment, when you give these patients steroids, the immunity component can be reduced. So there's a distinct possibility that these patients might be getting even infection with a fungus. The name of this fungus is what is usually asked by examiners. This fungus is an angioinvasive mycetoma and is called as Aspergillus niger. Well, if both respiratory failure and Aspergillus niger are given, then they're very close options. First answer is respiratory failure. And because I described about the aspect of Aspergillus niger, I want to draw a parallel with COVID-19. Like you guys are aware that when you're treating patients of COVID-19, you are giving them anyway steroids. So immunity will decrease, and therefore you would have seen increased incidence of rhinocerebral mucormycosis, what is casually called by non-medical people as black fungus. That rhinocerebral mucormycosis can cause death in COVID-19 pneumonia and can even contribute to loss of vision. So similarly here, Aspergillus niger is the fungus that is being talked about. I repeat again, rhinocerebral mucormycosis incidence is increased in COVID-19 patients on medical treatment with steroids. In sarcoidosis patients who are on steroids subsequently, then Aspergillus niger is the villain that can even contribute to hemoptysis. I'm very sure you will not confuse this with Aspergillus fumigatus. Aspergillus fumigatus has been explained to you or told to you with respect to ABPA, that is allergic bronchopulmonary aspergilloma. Now, I'm going to describe why is it going to happen that sarcoidosis will occur in a person. So there are two antigens to be remembered. One of the bacteria, Propionibacterium acnes, this is the bacteria that you study with respect to acne vulgaris, or it could be Mycobacterium tuberculosis with respect to a special antigen that is written as MCAT antigen. Now, the antigen presenting cells are gonna trap these antigens and are gonna present them to the CD4 cells in the lymph nodes, because lymph nodes are the site where ultimately the bad guys will get the final treatment, that is they're gonna be killed. Let us now see how the CD4 cells respond to this particular antigenic challenge. One, in this case, they will start producing gamma interferon. You are familiar that gamma interferon is one that is responsible for granuloma formation. And second that is produced here is interleukin 2. Well, that is responsible for CD4 cells and especially CD4 cell proliferation per se. So I said two things are gonna occur concurrently, and therefore there would be a non-caseating granuloma formation. The combination of these two responses will now result in non-caseating granuloma formation. You can take this to be representation of a macrophage. So all these macrophages are like uniting with one another to actually get rid of the antigenic challenge, and I've shown them in a basophilic representation. Then the CD4 cells, which I'm now showing eosinophilic, would be present all around this. So this kind of a image is even taught in pathology, where they actually talk about genesis of a non-caseating granuloma. The eosinophilic cells are the CD4 cells, and the ones which are basophilic here are the macrophages. And this that I've shown is a genesis of finally a giant cell. In fact, sometimes they might even like to go a little more deeper, and they would like to ask you about some inclusions that can be seen in this case. One can be an intracytoplasmic inclusion. This intracytoplasmic inclusion that I'm marking before you is called as asteroid body, and I am just gonna move up in the slide and just show you this asteroid body also. So I just repeat my statement. This that is currently on the focus is a IC, means intracytoplasmic inclusion, that would be seen inside this giant cell, and well, they love to ask about the name here. Second, you can also encounter what is called as Schaumann bodies. Well, why are Schaumann bodies bluish, as you can see, basophilic appearing here, is because of the calcification component, and I think you are very well versed with this fact from the pathology domain as well. I would like to highlight this once again, and I'll in fact use two colors to just show the two manifestations. The dot that I've shown here is the Schaumann body, and then the asteroid body shape is anyway can be made up. Asteroid bodies are intracytoplasmic inclusions. Schaumann is again intracytoplasmic but blue in color because of the calcification component. And well, these lesions could be occurring in almost all the body organs, especially like the lungs and the skin, and even the heart can be involved, as I explained, which can contribute to sudden death. I will now explain to you the clinical manifestations that will occur in this condition. Most of the questions that are given to you will describe a 35-year-old or a 40-year-old female who's coming to you with symptoms of progressively increasing cough. This could be associated with dyspnea on exertion that might give you an impression as if you're dealing with a cardiac case. But one statement that I'm making next will help you analyze that it is unlikely to be a cardiac case, but mainly a respiratory etiology, respiratory distress, primarily because stridor is written. Well, why is all this happening? You see, majority of patients with sarcoidosis develop a bilateral hilar lymphadenopathy that can even develop calcification, and you traditionally read about this in radiology as eggshell calcification. What I want you to understand is that if there is a bilateral hilar lymphadenopathy developing in a patient, then it can press on the airways, contributing to all the three manifestations to the level that in some questions he might even mention dyspnea on rest. DOE, dyspnea on exertion, DOR is dyspnea on rest, that could be occurring, and there's a high probability that this disease can be misdiagnosed as a case of pulmonary tuberculosis because night sweats can be present, weight loss can be present. So lots of time initially these patients are put on ATT, but there is no improvement. What would tell you that it is unlikely to be tuberculosis and likely to be sarcoidosis could be skin manifestations in this case. There are two very traditional skin manifestations that are asked on this topic. One is lupus pernio, which will mostly involve the face and will be painless. The second dermatological manifestation will be seen on the shins of the person. This would be erythema nodosum, and this is painful. So I definitely will show you images for both of them, but then these two terms are quite frequently used in the question and would help you know that this is sarcoidosis as a presentation. It is on the discretion of the examiner that if he wants to talk about a variant of the disease called as Lofgren syndrome. Now, manifestations of Lofgren syndrome, you can just look at the last two alphabets, that is EN. So from that you can remember the term erythema nodosum. Though I've written erythema nodosum earlier, also I've said they are painful lesions on the shins. They can be actually felt, so that's why the name is nodosum, and this would be associated with bilateral hilar lymphadenopathy. So well, what is the big deal? I mean, the point is both of these points are already given on the board. The additional fact here is that in Lofgren syndrome there might be an association with arthritis. Though it is less likely that he'll talk about Lofgren because he is mainly going to focus on the sarcoidosis component. But yes, this terminology is fairly interesting, so should be kept in mind. And well, for the subsequent manifestations, that is the fifth one, I would like to explain to you that this disease is a multi-system disorder. So right from top to bottom, large number of manifestations can be seen. If they give you a image based question in which they are not giving any history, you see in butterfly rash I had highlighted the fact that the rash would be contiguous. It would be involving not only the bridge of the nose but the cheeks, but there would be no area in between that would be normal. You see this particular skin lesion that I've highlighted before you, even if I don't give any history, if I give you history of a woman with respiratory difficulty, with dyspnea and exertion, dyspnea on rest, hilar lymphadenopathy, you know it is sarcoidosis. So even if they don't give any particular history, but you see a lesion like this on the face, on the nose, especially on the tip of the nose, not involving the bridge of the nose, and there's a distinct normal area in between, then well, this presentation is not of a malar rash, this presentation is a lupus pernio. So you need to have a good look at the image provided, and not every rash on the face is that of a butterfly rash of SLE. That's the message. Similarly, on the legs of these patients, you need to pick up these lesions which are definitely different from pretibial myxedema, because pretibial myxedema will be rather having a orangish discoloration of the skin, and along with that some symptoms related to hyperthyroidism can also be given. So you need to be familiar with these terms, that is lupus pernio and erythema nodosum per se, and both of these manifestations can be fairly dramatically occurring in the patient and are quite frequently asked. The subsequent manifestations of this person I will describe in this diagram starting from top to bottom. Well, CNS manifestations can be seen with sarcoidosis, and one of them is lymphocytic meningitis. You see, I'm not saying that this is a very common presentation, but because it is less common, that is why it is frequently asked. In fact, these lesions can even involve the optic nerve, and therefore optic neuritis as a presentation can also be seen. Even eye involvement is seen in these patients. So if I just draw a crude diagram here, this is the iris, this is the lens of the eye. So it's no big deal that you will read about uveitis in these patients. In fact, I've highlighted uveitis can also be seen with ankylosing spondylitis and even pars planitis. It is important for you to know these terminologies. Why? Because this particular term, optic neuritis, that I'm highlighting can even be seen in multiple sclerosis. But then multiple sclerosis only has optic neuritis. There is none of the features of uveitis and pars planitis, or for that matter of fact lymphocytic meningitis given. If you find that difficult to remember, then I would try to say another fact here. You see, because in these patients the granulomas can damage the posterior pituitary, so central diabetes insipidus as a manifestation contributing to polyuria polydipsia can even be seen with sarcoidosis. The bottom line is neurosarcoidosis and multiple sclerosis can be confused, but when it comes to multiple sclerosis, which is discussed in the CNS section of the app, it is only optic neuritis, and when you get so many manifestations over and above optic neuritis, you have to think in terms of neurosarcoidosis. Then even features of Sicca syndrome can be seen in these patients, that is dry eyes and dry mouth can be a manifestation. Traditionally you read that with Sjogren. Then parotid gland involvement will also be seen. In fact, per se, parotid gland enlargement in this patient can even contribute to bilateral seventh nerve palsy. Now, bilateral seventh nerve palsy is something that I have spoken about in Guillain-Barré syndrome. It's not again a very common thing. No, you traditionally read about Bell's palsy, but I am highlighting about facial diplegia. Medical conditions where facial diplegia is to be remembered is one, Guillain-Barré syndrome, then is sarcoidosis. There's a third one also, Melkersson-Rosenthal syndrome, that I'm not writing at the moment because that's relatively rare. But if you just get these terminologies right, especially the ones that I've highlighted at the moment, facial diplegia being responsible for or being seen with the following two conditions, you are bang on track for this topic. Now we will move down in this discussion and talk about the involvement of the lymph nodes. You see, this is the trachea, and then I'm gonna highlight the lung tissue here. So there is a distinct possibility that the hilar lymph nodes might become bigger, and they might be impinging on the airways. This is what was actually explaining why these patients would be having cough which is not going to respond to traditional medicines, antitussive agents. And in fact the patient is saying that I have tried everything available, including antitussive agents like dextromethorphan, but the cough component is rather worsening. So you need to think of some localized cause which is compressing on the airways, contributing to this manifestation. And if to this he adds also the fact that this lady is having hoarseness of voice developing now, well, because the lymph nodes could be pressing subsequently on the recurrent laryngeal nerve, and therefore voice change can be highlighted. If they enlarge even further, they can compress on the thoracic duct, that can contribute to even chylosositis. So the manifestations of this particular disease can actually keep on increasing, and all of these are mass effects of the enlarging lymph nodes. Lungs are anyway getting involved. Let's also recall, if the lungs will get involved, which lobe of the lung is usually involved. So I'm just using a different color to highlight the upper lobe involvement in these patients, it is upper lung fibrosis that occurs. Medical conditions where upper lung fibrosis occurs or upper lobe fibrosis predominantly occurs can be remembered by mnemonic by the name of SAT, which is discussed in another topic of rheumatology section as well. Well, I think you would have guessed it, where I have talked about upper lung lobe fibrosis, that is ankylosing spondylitis. Yes, the HLA-B27 positive condition. Tuberculosis will contribute to cavity formation, no, but ultimately if you heal and you prevent the cavity from enlarging further, there would be a healing process occurring contributing to fibrosis. So SAT, sarcoidosis, ankylosing spondylitis and tuberculosis are conditions where you read about upper lung fibrosis. We'll move a little infairly now, and I'll talk about cardiac issues in these patients. Well, heart can be involved in these patients, and there's a distinct possibility of them dying because of tachyarrhythmias. Ischemic heart disease has been a constant entry in all rheumatical conditions. In fact, there's no big deal that these non-caseating granulomas could obstruct the conducting pathway resulting in heart blocks. So it's not only that you would get tachyarrhythmias, there's a distinct possibility that you can get bradyarrhythmias in this condition as well. Even pulmonary artery hypertension has been documented with sarcoidosis. That's secondary to the lung damage, in fact. If pulmonary artery hypertension is present in any case, he will write terms like loud P2, or he will say diffusion capacity of the lung for carbon monoxide is reduced. I have explained DLCO again in the pulmonary function test component in the pulmonology section of the lab, but then you can see the huge amount of I would say flexibility an examiner will have to actually ask you features of sarcoidosis. As we come down, it could be the liver involvement occurring. In case it is the liver involvement occurring, it could contribute to hepatomegaly. The manifestation is called as granulomatous hepatitis. That's again a very classical term, so is worth its weight to remember. Then is the skin involvements that I've already talked about, the erythema nodosum, which is gonna be present on the shins and is painful, and on the face rather you would get this manifestation of lupus pernio. You see, this particular diagram that I'm making before you will become very jumbled up and will have lots of information. I want you to draw this diagram in comparison with that of rheumatoid arthritis and ankylosing spondylitis. If you draw these three, ankylosing spondylitis manifestations from top to bottom, rheumatoid arthritis, and then sarcoidosis, you will notice that sarcoidosis will be having the maximum number of entries, but you would definitely be able to compare these disorders because most of the questions are based on except or are saying all of the following are true except. So this would help you get a better orientation. Now I'll describe a bone marrow manifestation of the disease. I mean, look at the kind of depth of questions that he's asking. He's talking about sarcoidosis and he's asking about a bone marrow manifestation. The importance of this also you will understand in a while. These patients are having lymphopenia, and well, steroids also cause lymphopenia. So you are now stuck, no, whether you treat this guy or you don't treat this guy, because already the TLC is low. So therefore we have to start them on the lowest possible dosage of steroids. Otherwise, you know, the bad guy, that Aspergillus niger, no, that will come in. That can cause an angio-invasive mycetoma, that can cause hemoptysis in the patient. So you need to tread a very thin line while handling these cases. The next manifestation is very important from this slide perspective, though is being given at the bottom, endocrine manifestation of sarcoidosis. See, these granulomas, they are capable of causing synthesis of vitamin D3. I'm saying a very surprising thing, that these granulomas are actually having this enzyme 1-alpha hydroxylase. They can actually cause synthesis of 1,25 dihydroxycholecalciferol, that is vitamin D3, and as a result of this you will notice that every time in endocrinology when I've talked about calcium being increased, sarcoidosis has always made an entry. Hypercalcemia, you will notice that in almost every MCQ of hypercalcemia per se, one entry will always be sarcoidosis. And why you want to remember that, or why the examiner wants you to remember that, is because of the fact that if you are gonna give steroids to these patients, then sarcoidosis will improve, the granulomas will resolve, the synthesis of vitamin D3 will stop, and the calcium values will also come down. So one of another important statement that I made in endocrine section but is being repeated at the moment is sarcoidosis is an example of steroid responsive hypercalcemia. I have taught you about steroid responsive nephrotic syndrome, that is minimal chain disease, no? But today I'm teaching you steroid responsive hypercalcemia is sarcoidosis. One more example I can give you of steroid responsive hypercalcemia that would refresh your memories also from endocrinology, that is vitamin D3 intoxication. Remember guys, I was talking about a guy who's joined a gym and his coach, he has started giving him health supplements. In these health supplements, you see these coaches, etc., they just trying to make extra money because a guy wants to look good and wants to look very muscular. So they're giving him anabolic steroids and they're pumping him with vitamins. When you give too much of vitamin D3, it can again contribute to vitamin D3 intoxication. Calcium values can spike, and this guy who is trying to build up muscle in the gym can actually even die. So vitamin D3 intoxication is again treated with steroids. We give hydrocortisone for these patients. So I have today taught you two examples of steroid responsive hypercalcemia. One is sarcoidosis, the topic of interest. Second is vitamin D intoxication. And hypercalcemia must be remembered as an endocrine manifestation of the disease because it is usually given towards the end. We tend to neglect the finding. I also want to sensitize you to the fact that the cranial nerve, the most common cranial nerve that is getting involved in sarcoidosis happens to be the seventh nerve. And apart from seventh, even the second can be involved. Why? Because I spoke about the manifestation of optic neuritis. No? I was teaching you optic neuritis is the feature of multiple sclerosis, but optic neuritis in combination with so many things is not multiple sclerosis. That would be sarcoidosis. Let me just write it down for the record purpose. What are the cranial nerves which are involved in the current topic? It is the seventh cranial nerve as well as the second nerve that can be involved. And when it comes to per se bilateral seventh nerve palsy or facial diplegia, there are multiple causes of it. Guillain-Barré syndrome and sarcoidosis is what I've already told you. I would just like to add an infective cause here as well, that is Lyme's disease can also contribute to a facial diplegia occurring in a patient. Ocular manifestation of these patients are in the form of uveitis and paraplanitis, whereas uveitis was also discussed as extra-articular manifestation of ankylosing spondylitis. But in rheumatoid arthritis, I did not say the word uveitis. There I used the term keratoconjunctivitis sicca, scleritis, episcleritis, and scleromalacia perforans. Be very thorough with the ocular manifestations of all the diseases in rheumatoid section that I've discussed before you, and I would rate this slide as the most important slide for the topic of sarcoidosis because there are so many manifestations. So try writing them down. CNS manifestations, then cardiac manifestations, lung manifestations, the liver one, then subsequently bone marrow involvement, and lastly it's going to be an endocrine involvement. So if you try to get an orientation of this particular disease the way I have manifested or I have tried to explain before you, you would be able to retain this better because I can use any funny mnemonic and say, okay, this is what is to be remembered, but mnemonics are not recalled in the exam. But if you serially and sequentially try to remember the manifestations, it would definitely make you feel more comfortable and will improve your strike rate in the final exam. We shall now be discussing regarding a workup of a patient of sarcoidosis. Well, first of all, we will be doing a chest x-ray of this particular person where we will be able to identify the lung disease. In fact, if the question says, what is the first investigation to be done in patients of sarcoidosis, it is not a HRCT. It is not going to be answered as bronchoscopy. The most common investigation to identify lung disease overall as a statement, you see, even if you look at what I'm writing on the board here before you, even if I'm not talking about sarcoidosis, if I just say what is the common investigation done to identify lung disease, it is just X-ray only. And most of the time the hilar lymphadenopathy of this condition will be substantially present on a chest X-ray for you to identify, and in some cases actually it might even increase further and may be available as a radio opaque shadow because there would be calcification around the enlarged lymph nodes which are compressing on the airways. Eggshell calcification is also read by you in literature of silicosis, which happens to be the #1 occupational lung disease in India. If you look at this chest X-ray that I'm showing at the moment before you, the white haziness in both the lung fields can actually make you misdiagnose this condition as a bat wing edema of cardiogenic pulmonary edema or heart failure. But per se, if you look at the size of the heart here, the cardiothoracic ratio of this particular patient definitely looks to be normal. There is also normalcy of the CP angles. I mean, whenever there's heart failure, there's pleural effusion present, but in this case you can see there's no pleural effusion, heart size looks normal, so I will not answer this as bat wing pulmonary edema in a patient. In fact, there are multiple pulmonary infiltrates which are present all over the lung field, and there's a distinct possibility that if this X-ray is given to you without any history, you might even answer this as miliary tuberculosis. Though miliary tuberculosis will have multiple white spots, but even this is having a haziness. So I've seen lots of guys casually messing up bat wing pulmonary edema versus miliary tuberculosis versus that of sarcoidosis. I want you to actually go through the cardiology section where a specialist talking about bat wing pulmonary edema, and well, when it comes to the respiratory section, I want you to be very clear that in miliary TB it would be multiple whitish spots in bilateral lung fields, whereas here it's more of a haze, HAZE, a haze that is present. For the completion of the topic, it is also important that I mention before you the radiological stages that are given in the textbook for the lymphadenopathy progression in this condition and evolution of findings. It is stage 1 that has hilar lymphadenopathy. Listen to the words carefully. But if you read a combination of hilar lymphadenopathy plus peripheral infiltrates like the one that are shown in this X-ray which are causing a haziness, it would be stage 2. If you're having only infiltrates in the chest X-ray, it is stage 3. You see, the normal impression of ours is that hilar lymphadenopathy implies a much more severe progression of the disease. No, the more progressive nature of the disease will actually cause fibrosis. Please appreciate that ultimately the lung will become fibrosed in this condition. So these stages are basically representing the deterioration. Hilar lymphadenopathy is an early presentation and fibrosis is relatively a late presentation. Coming to the investigational choice for this condition, I would like to go in for a biopsy. I can either go in for a transbronchial biopsy or I can go in for a endobrachial biopsy. Well, there are two terms I said. One is endobrachial and second is transbronchial biopsy. Well, what is the difference between the two? The difference between the two is that if it is predominantly a parenchymal involvement visualized, let me say on a chest X-ray, then I'll advise to go in for a transbronchial biopsy. On the other hand, endobronchial biopsy basically means that the lymph nodes have become bigger and they're protruding into the lumen, or they're causing a bulge in the lumen of the bronchus, so you can obtain them right away. So endobronchial biopsy is mainly for lymph node enlargement. Do get the perspectives right. I repeat the statement once again. If the lymph nodes are enlarging and protruding into the lumen, or for that matter of fact, they're displacing the bronchus, which can be visualized on X-ray or on a CT chest, I can go in for an endobronchial biopsy. But if it is parenchymal involvement, predominantly it is a transbronchial biopsy. This is to be given priority over the report of bronchoalveolar lavage. The bronchoalveolar lavage findings in this case is lymphocytosis. Now listen to my words very carefully. Earlier in my previous slide, when I was teaching you the hematological manifestations of sarcoidosis, I had taught you that the hematological manifestation is lymphopenia. Lymphopenia is a hemat manifestation, whereas lymphocytosis that has been taught to you right now is a bronchoalveolar lavage manifestation. This is over and above what you need to remember also, that in the same lavage fluids we can also check for CD4 CD8 ratio. Traditionally, we read about CD4 CD8 ratio in literature of HIV, but today I'm teaching you sarcoidosis topic where CD4 CD8 ratio more than 3.5 gives more credibility to the diagnosis. I've also tried to explain to you the fact that suppose in questions you have to select between BAL lymphocytosis versus CD4 CD8 ratio, then BAL lymphocytosis gives more credibility to diagnosis as compared to CD4 CD8 ratio. That's based on the percentage sensitivity and specificity of various investigations. Overall, the best test is endobronchial / transbronchial biopsy. Your main answer is biopsy. I need a tissue diagnosis. If biopsy is not given in the options, you see, if biopsy is not given in the options, then you need to answer bronchoalveolar lavage with lymphocytosis. Contrast from the hemat picture of lymphopenia and overall CD4 CD8 ratio more than 3.5 is again suggestive of diagnosis. I shall also be doing a HRCT chest in these patients to demonstrate the lung involvement, but as I explained to you that first investigation would not be HRCT, first would be a chest X-ray. On HRCT chest, we will be able to identify a very classical sign called as galaxy sign. In fact, I've just shown it here, like the galaxy would be a constellation of stars. So galaxy sign term can be used, and along with that obviously we can see substantial lymph node enlargement. We can definitely see lung fibrosis if it is associated. The fourth investigation for this topic is for academic reasons, otherwise we usually do not perform it, that is gallium 69 scan. Well, here they would come some very specific terminologies, because per se in this condition even the salivary glands can be involved, even the lacrimal glands can be involved. So the term used can be panda sign, the panda. You can see here the blackness around the eyes of the panda. Similarly, you can see the lacrimal gland and the parotid gland involvement in this patient. So very classical term, panda sign. One panda sign that you study in surgery is for especially anterior cranial fossa damage, but here I'm talking panda sign on a gallium 65 scan. So both are different. Another finding that can be present in these patients would be called as lambda sign. So what I'll do is just draw it the way they will do in mathematics. What it represents is the enlargement of bilateral hilar lymph nodes, that is the right and the left hilar lymph nodes would be enlarged, and this can contribute to development of stridor in the patient. Apart from this, there can also be enlargement of the right paratracheal group of the lymph nodes, which will further worsen the stridor component in the patient. The same finding that I have said in multiple choice questions can also be written as a chest X-ray finding of 1, 2, 3 sign. Well, Harrison is not mentioning these classical terms because you see these are very late presentations. Our objective is always an earlier one. But whenever you read terms like 1, 2, 3 sign, you read about lambda sign being documented. Lambda sign is a feature of gallium 67 scan because the lymphadenopathy can also be picked up. I would also like to do a PET scan in this case. Well, here I usually get queries that sir, PET scan is for metastasis from a cancer. Why are you doing a PET scan here? I want to check for extrapulmonary involvement because as I told you, this disease can even involve the brain. So neurological manifestations can be seen even in these patients. And to pick up this extrapulmonary involvement, it is PET that is recommended. Then diffusion capacity of the lung for carbon monoxide can be given to be lesser. There are two reasons why it is lesser. One can be pulmonary artery hypertension. Second is pulmonary fibrosis component. Both result in a decreased diffusion capacity. I'll do a cardiac MRI because I want to pick up the granulomas involving the heart, and that has definitive diagnostic and therapeutic implications because these patients can develop both tachyarrhythmias as well as bradyarrhythmias. The eighth test is again loved by examiners, ACE levels. You see, angiotensin converting enzyme levels are found to be elevated in certain conditions, which can be remembered by a mnemonic by the name of SGPT. Well, in alphabet S, we are talking about obviously the topic of interest, that is sarcoidosis. The alphabet G would stand for Gaucher's disease. So just try to remember it here only. Otherwise, it becomes overbearing to remember so much information. Alphabet L here would stand for leprosy, that is also called as Hansen's disease in India. And then alphabet T here would stand for tuberculosis. So I would like you to specially remember these terms, especially for the mnemonic SGRT, ACE levels are elevated. Then is a test from historical perspective, guys, Queen's test. Queen's test is not done as of now. I repeat the statement. Queen's test is not done as of now for diagnosis of this condition. It's only for historical purposes because of the risk of prion particle transmission, and therefore a person can land up with Creutzfeldt-Jakob disease, the classical Creutzfeldt-Jakob disease. Prion disease again has been discussed in neurology section, so you can go through that there. Queen's test per se is not used anymore, and that's only for historical importance. Most of the time, the investigations that I mentioned, no, they will just fill up the choices in the MCQ. As such, when it comes to diagnosis of this condition, we can first do a chest X-ray, then plan a biopsy of this patient. If the lymph nodes are enlarged right away, that would be a CT guided biopsy, or we can go in for a bronchoscopy guided biopsy. However, in some cases where the diagnosis may not be so clear or the lymph nodes may not be very substantially enlarged and there might be only peripheral infiltrates present, then definitely these supportive evidences would help you in diagnosis. The mainstay of treatment of these patients is steroids, as is the case in almost all the rheumatological disorder. He can also ask you regarding the steroid sparing agent that we might use in these patients because there's a lymphopenia component coming up, right? I don't want him to suffer from infections, so I can be using in this case hydroxychloroquine. I introduced hydroxychloroquine earlier for management of photosensitivity in a case of systemic lupus erythematosus. Along with this, other drugs which have been recommended for this condition are methotrexate. I just want to highlight, wherever possible, try to titrate on the lowest possible dosage of steroids or immunosuppressive drugs. And yes, infliximab has also been used in management of this condition. In fact, I have spoken about infliximab earlier as one of the major biologicals that will help in improvement in the prognosis of ankylosing spondylitis. I have also talked about infliximab helping in healing of enterocutaneous fistulas in inflammatory bowel disease. And today I have talked about the same drug, infliximab, but with respect to management of sarcoidosis. So these are conditions where infliximab has been talked about: ankylosing spondylitis, inflammatory bowel disease, and then obviously the topic of interest. Most of the questions of this particular topic will revolve around these manifestations that I've written here before you. And as I said, I mean, multiple sclerosis might be a sore point that you might have to rule out in the question, because multiple sclerosis mainly will be having Uttoff's phenomenon. It will mainly talk about a Caucasian female. It will not talk about any lymphadenopathy. So the manifestations of multiple sclerosis versus sarcoidosis are grossly different, and there is absolutely no reason why mixing up of the two informations is ever possible with respect to the two disorders. And if you just get ankylosing spondylitis versus rheumatoid versus sarcoidosis in the right perspective, I think you would be bang on track to solve multiple choice questions on this topic. These are the important details that I want you to be very thorough with. Thank you so much for hearing me out and having the patience to endure all these facts. Thank you.